There's still a lot of stigma around getting mental health treatment, how we talk about mental health. Unintentionally, I hear people say, oh, well, they have mental issues or behavioral issues. We call them issues. When we talk about diabetes or medical conditions, we don't say they're diabetes issues.
Yeah.
Don't quote me on the statistics, but I think it's almost like 50% of long-term mental health conditions happen before a child's 14.
Yeah, that sounds right.
And then when you get up to 24, it's like 75%. So instead of solving the most complex problems, I'm looking at, okay, how do we get in front of this? How do we get more proactive?
There has been a school shooting outside Denver.
School shooting.
And the evil of this unspeakable act.
Kids go through so much now. There's a school shooting, routinely. Like, that's traumatic, whether you see it on the news, whether they did a drill at their school, like all of that. So we really need to have that lens from everyone in our system.
If you could snap your fingers and change one thing today about youth mental health that you think would radically improve the lives of all of our young people, what would you snap your fingers and do?
Yeah, I think there's so many. I think one thing that comes to mind is
Christine, thank you so much for being here. I'm so excited to chat with you today. I've gotten to know you a little bit over the last year, and you have now become the executive director of behavioral health at Optum UHC, really overseeing all of the operations for behavioral health in North Carolina, which is amazing. It's an interesting time to be in North Carolina, as we were talking about before the show, given all of the federal cuts that are coming. But regardless, there is so much amazing work that's being done in North Carolina by your team and by all the other teams here trying to support the communities. And so I'm really excited to talk and just hear and learn a little bit more from your experience about what you've seen over the last few years, what's worked, what problems haven't worked, what solutions have not worked for those problems. But I want to take a start by going back to your early career, which I know was in addiction work. And I want to hear maybe like what drew you to that work, and maybe like what were some of the early experiences that you had that really captivated you in this problem of supporting others?
Yeah. So, thinking way back, that I kind of felt, things happen for a reason. So when I started my work, when I got my internship, it was with the county health department. I was working with kids who were at risk of abuse and neglect. Some of them had already been removed from their families. Some were in kind of the pre-engagement work. So we were really trying to keep that family together. So it was really unique. And it wasn't necessarily that I chose and thought that was what I wanted to do. But after having that experience for 9 months and really seeing the children get hospitalized, how their families kind of fell apart around some of these unexpected, whether it be addictions, whether it was abuse or neglect or suspected abuse and neglect, that really gave me such a strong feeling for the public sector and what a need there was, because it was all different circumstances. It was some families that, lived in poverty, and they weren't necessarily intentionally neglecting their kids. They were just struggling to make ends meet. Or there was families that had this long history of addiction within their families. So it really varied. And, I go back to as an intern, right? So you're young, you're in your 20s, you go into hospital. They're like, okay, well, this is your responsibility. You need to go in there, assess this child, and tell us what to do because she's really difficult and nobody wants to work with her. And just going in there and hearing her side of the story, she was probably 15, 16. Had been placed with her grandparents because mom was dealing with some substance use, and really she just needed someone to listen to her. She was acting out, having some externalizing behaviors, but really it was because her whole life had been disrupted. And she was in high school. She had moved away from her friends because her grandparents lived in a different area. So she was going through all this trauma, and what even some of the professionals were saying about her was, oh, she's just difficult. She just doesn't listen to anyone. And it really gave me that's kind of when I knew work was so important, and hearing these kids and these kids having a voice really could change kind of the trajectory of where they went.
Was it the stories of transformation or the stories of the system failing that really captivated you?
I think it was just listening to the kids and realizing, I even remember, again, young intern people saying things to me that I just knew weren't right. And I was I was the voice for the kids, really being their advocate and just giving them the space and time to let someone hear their stories instead of it being, okay, you're in a group, you need to talk now. And if you don't talk, you're non-compliant. Really just saying, okay, we can sit here for 10, 20 minutes if that's what we need. And I'm just going to be here with you.
Was there a prevailing set of clinical ideas about that maybe you came to believe as to why these kids were not being heard or why no one was taking the time to do this? Or was it sort of like a something else that was, because you, it seemed obvious, right?
Yeah, I mean, I've always had a strong belief in like family systems and that, you know, if a kid's hurting, if a kid gets hospitalized, especially for mental health, there's bigger things going on within that family system, even in the best of families, even families who aren't going through the child welfare system. And it was really, I mean, I think people had good intentions, but I think I saw things, people weren't trained enough. They didn't have the support that they needed. I worked with foster parents at that time. And what I found was when foster parents knew there was the clinician they could call at 2:00 in the morning or someone had their back if it was a difficult, challenging situation, they did much better. They kept kids longer. They were able to help kids achieve permanency than those ones that maybe just were so overwhelmed. They didn't know where to turn. They didn't have support. No one was kind of wrapping around them. I think they had good intentions. They wanted to help kids. Yeah. I think it just was so difficult because no one was supporting them and they didn't know where to turn. That's kind of where I saw some of the challenges within a system.
So that was one obvious challenge, which is like the kids are not getting what they need, but also the supporters are not getting what they need to help support these kids.
Right.
As you went through your experiences being a little bit more on the front lines and actually doing some of this work, what were some of the maybe obvious problems to you then that you saw, just like you saw with these kids having no one to listen to them and actually understand their problems? What are the things that you saw back then that have really continued to stick with you over your journey now, becoming more of the system builder that you are in your work?
Yeah, I mean, so I think one of the things that sticks with me is that every member you're working with matters, whether that's a child, whether that's a family, whether that's an adult. And really, if you can understand that, even though I'm working on a systemic level, I'm developing programs that impact hundreds of individuals, there's always going to be those individuals that don't fit in a perfect box or that the one solution doesn't work for. And so I think we always have to keep that in mind. We can have the best laid plans. We can want systemic change and improvement, and that's great. But we also have to be willing to still think outside the box when we need to help, you know, whoever individuals and just support the system as a whole. You know, there's a lot of change right now. I think you mentioned this, you know, some of the government and things like that we're all trying to navigate. And if we don't do that together and work together, I don't think we're going to be successful.
I find that actually a really interesting dichotomy between building a system and building unique support. And like what you're actually trying to do and what it sounds like the solution in your head is you have to build a system that can deliver unique support. And anytime you build a system or architect something that has some semblance of scale, you're by definition trying to systematize things and trying to bring process to stuff. But process, as I'm sure you've seen and I've seen, it can eliminate the ability for people to be creative and unique. So, like, can you talk to me a little bit about what does that actually mean for you? Like, how have you seen it successful to empower the supporters or clinicians or foster parents? Like, how have you seen it effective to actually support them in delivering a unique set of care for people? And maybe like, is that even right? Like, is that the right way to think about it?
Yeah, I mean, I think so. I'm really fortunate to, you know, I started my career in Illinois and then have been in North Carolina here for close to 20 years. And working in this, so most of my systemic work has been here in North Carolina in the Medicaid space. So not only my job now with United Healthcare, but prior to that. And North Carolina has been extremely supportive in pilots, in innovation. I think that's how you and I met originally. You know, some things is kind of one of those things that they brought as a unique, let's try it, let's see how this impacts. So we've been very fortunate, I think, here in North Carolina to be able to do some of that innovation, maybe think outside the box, maybe try something. You know, I think about In my prior role, we did a pilot that was with emergency rooms. So kids that were in emergency rooms, kind of getting stuck in emergency rooms. And we thought, well, why are these families not wanting these children to come home? And it was exactly what you were talking about. They didn't feel supported. They thought, well, if something goes wrong at 2 o'clock in the morning, who do I call? I know to take them to the ER because that's what's available. And we were able to put a pilot in place that really gave response not only to the child who was in the hospital, but to the family, and could quickly mobilize. And the state, allowed us the flexibility to do that. And then the state actually went out and researched a similar model. What are other states doing? And they brought that to North Carolina. And now North Carolina has these pilots of the MORC program. There's a similar type of model.
Wow, I had no idea. So you were part of the initial team for the research on the MORC program.
Yeah, so we called it rapid care services. So it was slightly different, but it was kind of that same concept of how do you rapidly support children, families in these scenarios, and then the state really took it to that next level, which is really exciting to see that now more and more of that has opened up.
That is really cool to me because any state that I go to now, a MORS type system is absolutely core to the system of care for supporting communities at risk. What can you give me the history of that? Like, for you, what did you and your team see in that problem, or how did you come across that problem to begin working on that? Because I think let's start there. I'm super curious.
Yeah, I think it was a combination. One is kind of my previous clinical background, so working directly with kids who did go to hospitals or emergency rooms, but then hearing from the hospitals themselves, like these kids come, they don't really need to be hospitalized. They kind of get stuck here at times, but they don't necessarily need residential care. So how do we look at this differently? And then we had some great provider partners that we just got in a room, kind of brainstormed, like, what can we do differently? How do we work together? What can we try that may be effective? So that's, it's really takes a whole system. So on the insurance side, you can fund it, you can build a program, but you need someone to deliver it. You need someone out in the field, and you need willing partners. So it doesn't work if the hospital doesn't want anyone coming in to do assessments or to collaborate, or they don't want to call you when kids are there. So you really have to get all the partners kind of thinking the same way, or at least willing to give it a shot,
Which is no small feat to get all of the stakeholders needed to deliver care in line. And I think one of the themes of this podcast is to try to give some helpful and tactical advice on what's worked. And it sounds like for you, this research phase of bringing providers together, talking to hospitals together, is really critical. What have you put in place now at Optum UHC to be able to do this? Is there a framework that you think about in terms of how do I actually get in people from the hospital at a regular interval to actually have these conversations? Is this something that you have a playbook for?
I mean, I think it all goes back to relationships, checking in with, because my needs or my priorities may be different than a hospital's priorities or providers' priorities. So kind of listening, you have to really find those relationships and listen to what are there and where those opportunities are where we align. So you have the same problem that I have the same problem. We all want less ED utilization when we don't have to. So how do we solve that together? And I think this, in North Carolina, the state has done a really good job of kind of outlining a roadmap of here are some priority areas. Here's some of the things we want to fix. Here's some of the things we know we can do better. That has helped providers, even community stakeholders, us all kind of align around some of those key elements to then figure out, okay, what do we do next to make this successful?
Yeah. And I imagine having the, Kelly and before her, the shared vision is easy to align people when it's saying, hey, this isn't just our team over here talking to one place. It's we've acknowledged that this is a statewide issue, which I think again speaks to, this is not a one party solution. This has to be alignment from everything all the way up to the state level, through the plans, through the providers, which again is really hard. And I think is a testament to the sheer amount of willpower that the people across North Carolina are trying to solve this problem with. You mentioned it, and it's going to be a little bit of a tangent, but I would be curious to talk about the changes that you've seen, because there have been a lot of changes. You could correct me if I'm wrong, but I suspect that you witnessed the tailored plan change. I suspect that, you've now been and seen a part of this CFSP plan. There's been a lot of structural changes to the way that health plans and providers are getting linked with different communities. Can you talk me through some of the history of like the changes that you've seen and some of the more impactful moments that you have been a part of when it comes to aligning this whole system?
Yeah, so I mean, I think when I first started in North Carolina, some of the waivers for behavioral health and intellectual and developmental disabilities were pilots. So they were brand new. It was something the state was trying. They had moved into managed care, essentially on the behavioral health side, where most states do that the reverse. A lot of states will try the medical side in managed care, but North Carolina, did it on behavioral health and said, okay, well, how do we do better at this? How do we have better outcomes for individuals? So,
Do you know why that choice was made?
I mean, I think they were just an evolving system. We had some really great thought leaders at the state that, these waivers existed. North Carolina wasn't the only one, but there was a real passion for the intellectual and developmental disability population, getting people out of institutions. So how do we do more community-based care? Obviously, there was cost savings to it as well, which just means, there was more than dollars. You could spread, do new things. So it was really kind of exciting. I think that the state was thinking that let's try this, let's see if it works. And then it evolved from there. Then the waivers went statewide. And from there, they kind of said, okay, we want to do integrated care, which I think just makes so much sense, right? Like, we need to treat the whole person, not just one part, and parse it out. You're over here and we're over there, which is how the standard plans, which I work for currently, evolved. And then tailored plans came in. And I think it all really makes sense. They're all designed around whole person care, behavioral health, and medical care working together, primary care kind of being the quarterback, for lack of a better word, on our standard plan members. But I think one of the challenges for providers is you went from the system, particularly in the behavioral health space, you're working with one plan primarily, depending what county you were in, or if you were across the state, maybe a couple. So now these standard plans came in. So now you have 5 of them, plus your historic BH plan. So it got really confusing for them, and it's a complex system. And I work in it, so I can't imagine as a member or an individual trying to learn how to navigate that, or a provider. Now I have to contract with 5 plans instead of just one. It's a lot. So I think it's still evolving.
With the advent of the transition to tailored plan, the standard plan system, what I think there's from the people that I've talked to about it, both inside North Carolina and people outside who have observed it, there's a lot of pros and a lot of cons with doing the sort of split system. What do you think have been the most, like, what are the most impactful or positive things that you think come from the sort of tailored plan, standard plan system that the state has created at this point?
I mean, I think you get to think about things differently. So in all transparency, I was kind of historically on what would now be the tailored plan side of things. So working with your individuals with higher needs, more complexities, children that needed residential care, adults that needed those assertive community treatment teams or really intensive services. And to now I have a whole different perspective being on the standard plan, and my thought process even has changed. So instead of solving the most complex problems, I'm looking at, okay, how do we get in front of this? How do we get more proactive? How do we identify kids earlier? As we know, most of, I think, don't quote me on the statistics, but I think it's almost like 50% of long-term mental health conditions happen before a child's 14.
Yeah, that sounds right.
And then when you get up to 24, it's like 75%. So what if we had treated individuals earlier? What if we had gotten them help? What if we had gotten them into therapy? What if we had given them pro-social supports? What if we done all those things on the front end? How much of this long-term residential treatment, some of those more complex needs, could we have prevented? So it's really helped me. I know the bifurcation is hard on a provider system, even on the hospital system. So that's probably one of the cons of working with so many insurance plans in a Medicaid market. But I think it's also helped us really stay focused on prevention and then specialty care. So I think there's value in that as well.
Yeah, actually, I never considered that as like the focus of the two, which is if you've got a less someone with less needs or a population with less needs, you can focus more on the things that are not as focused, right? You can focus on things that are more broad, more upstream skills-based training as an example. And then if you're just focused on helping the people who are most complex, you don't have to necessarily worry about that. And I guess then the only challenge is making sure the transition between the two is as smooth as possible for people. But I really like that framing. And I think it's sort of this, it's at least known to me, but it seems like there's a known problem that prevention is hard to invest in because of churn off of plans. Do you feel like because the focus of the standard plans gets to be just on the prevention, that it's easier to underwrite investments into preventative type solutions as opposed to if you were in charge of a full population, including some of those complex members?
I mean, I think so, yeah. And I think, I'm fortunate. I mean, obviously I work for a large organization. So we have a foundation, I think, that has allowed us to make community-based investments. So we've done a lot of work in investing in school-based health. And it's not just for our Medicaid members, it really is to address kind of community needs. So anyone can access the school-based services, not just our members, and really changes the trajectory of a community.
Yeah.
So, I mean, I think that's one of the positives, that we're able to have those investment dollars to do some of that. And I know that, the state's trying to do that as well. One of our partnerships is it's a public-private partnership with the state. And so we both invested jointly in some of these school-based care to build the program to serve more kids across the statewide. So I think those are the things that when we can focus together and work together, we can have a bigger impact.
Yeah, totally agree. Let's talk about current state of like your world in terms of the problems that you're trying to address. So, the state has its list of priorities, which is all aligned. What are the things that you are most excited about that you're working on right now? And this could be either because of your experiences previously on the field seeing these problems, or just because you've gotten excited about them. Like, what are you personally most excited that you're trying to solve right now?
Nothing is me alone trying to solve necessarily,
Sure.
But when I think about just stigma in general, there's still a lot of stigma around getting mental health treatment, how we talk about mental health. Unintentionally, I hear people say, oh, well, they have mental issues or behavioral issues. We call them issues. When we talk about diabetes or medical conditions, we don't say they're diabetes issues,
Yeah.
So, but I think the positive when I look at that is people are talking about it. We are reducing the stigma. I mean, do I think we're where we should be, that getting treatment, whether it's for substance use disorders or mental health, is fully where we want it to be, that it's as common as going to your primary care when you have a sore throat or whatever? Probably not, but I do think the fact that people are having those conversations is really great. And I think that's one of the problems we need to solve to make that more comfortable for people, more normal for people, more accepted, that, we can talk about these things. We can get people the help they need without it feeling like, okay, I'm going to get the help, but don't tell people I went to this treatment center or did whatever that is.
Stigma's a hard problem. Like, what do you think are the things that need to happen to move past stigma, at least in this state?
Ongoing education, awareness. I think people say words like mental issues or behavioral issues, not intentionally, not necessarily because they're trying to be mean, or it just comes out that way. They've never been kind of made aware, like there's different ways to use people first language or think about it differently, or not be afraid if someone tells you, hey, I'm thinking about hurting myself, to ask them, like, tell me more about that. Like, how can I support you? What do you need from me? I think it's a scary thing. I remember the first time somebody told me that they were thinking about killing themselves, and I had to make the decision, do I send this individual, recommend they go to the hospital, do I bring the ambulance, or do I kind of sort through this and figure out if we can come up with a safe plan for them to stay at home, get them the help they need? I mean, that's overwhelming. Like, you hope you do it right. You hope you make so I get that. And I'm, went through a lot of school. I've been doing this for a long time.
Yeah.
But I mean, I think the more we can talk about that and say, if someone says this to you, it's okay to talk with them about it. It's okay to have those conversations. I think the better for everyone,
You mentioned much earlier in the conversation when we were talking about your very, very early work and supporting some of these youth and seeing others not be able to support them well. One of the reasons you said was they weren't trained enough. So it sounds like there is a theme in your belief about how we can step forward, which is we need to know more. We need to have more people who are more trained and more informed when it comes to these things. I think basic crisis intervention training I'm totally aligned with. That seems like a very obvious one that we should do. And I've seen a lot of actually really cool work at schools that they are trying to deploy things like this, but it's not easy to get the 10 million people in the state up and trained. Is there anything else that makes you excited about the tides that are shifting when it comes to stigma here? Like, do you think we're making progress?
Oh, absolutely. I do think we're headed in the right direction. I mean, the suicide rates are going down, so that's positive. I mean, any one suicide attempt is too many, in my opinion. But the fact that we've seen decreases in that tells us we're moving in the right direction, that people are getting help or people are feeling more comfortable asking for help. Whatever that's turning, I think that's a positive thing. I mean, I haven't seen as much, you see on the news now, much more commonly, athletes, actor, all of those people coming out and talking about this, like disclosing their own experiences and what's helped them get through a trauma, get through, treatment. So I do think the fact that some leaders, some mentors, that's great. I mean, I'd be curious, you're very involved in this work and with mentoring and things like that, if you have thoughts on kind of where we see this.
It's a good question. And there's probably a lot of things I could say about it. I think that I don't find that young people have internalized stigma. Like, I find that at least, and it's a self-selecting group because the kids that we see are reaching out for help. So I'm sure there are many who have internalized stigma still, but the kids that reach out for help, they are not ashamed of talking about their illness. The ones who engage with our social posts, they're not ashamed to say that they suffer from depression or anxiety. In fact, in some regards, I think there might be an over-identification with some of these things. But so in that regard, I think stigma is gone. Where the stigma feels like it still exists is in the connectivity between youth and other people, specifically other people who have the power to do something. There's a lot of challenge that young people have in terms of opening up to their peers because of the dynamic of the social situations they live in. That will always be a challenge, but I think where I feel like we as a state and as a society need to do better is finding ways to open up communication channels between youth and adults. So that way, if there is an issue, there's at least a low enough level of stigma or a single connectivity point in that youth's life where they can go to someone and say, hey, this is actually a problem for me. And that is feels like there's more work to be done there. That was my little rant on stigma.
Makes perfect sense. Yeah, that's true. I think kids are much more open, very accepting. Sometimes it's the adults that might get in the way.
Yeah, and I think adults play such an integral role because unlike adults with mental health issues, young people, they don't have the independence to actually make a lot of the structural changes in their life yet, whether that's because they're a 13-year-old and they live with their parents or because they're just not cognitively developed enough to be able to do that. So you actually do have to rely on the adults quite a bit, whether that's at school, at home, which I think, for youth with very complex mental health illness, I think all the research shows, and I'm not an expert on this part of the literature, but all the research that I've seen shows that integrated family care is better when you can get the parents involved. Now, the challenge is it can be hard to get the parents involved sometimes, but when you have the parents involved, the treatment outcomes are better because the parents are so integral into that youth's development. But anyway, not here to talk about that. We'll talk about you. Why don't we switch over to, you've gone from being boots on the ground to launching new programs to now leading statewide efforts to deploy solutions. You've been very integral at the state level as well. What are some challenges that you've found and some stories that you have about launching things at that level of scale, like across the hundreds of I should maybe know this, of how many members you all have, but hundreds of thousands to millions of members that you have across the state, like what are the challenges that are posed by being at that level of scale?
And this may be a personal kind of bias of mine, but things just don't move fast enough. Like whether it's getting the funding approved, getting the legislative approvals, whether it's paperwork has to be done, internal approval, like there's a lot of steps to making things happen. It's much easier when you're working with one individual at a time. You can make that happen a lot more quickly. But when you're thinking about implementing something that needs a lot of infrastructure, that maybe needs data sharing agreements, that maybe needs, everyone to be aligned on when the kickoff meeting, all of those things, it just moves a little slower than I would like to see. But I mean, I think the bottom line is it gets there eventually. Just maybe I wish it happened a lot quicker.
Yeah.
So.
Well, I appreciate the push for urgency. Have you found any, I've never sat in your seat, and I imagine if I were to be thinking about rolling out a statewide program for some specific population, I'd have to have conviction that there are enough providers or enough resources across all of the areas of the state, to be able to do it. We have the luxury of being virtual, so we can reach everyone anywhere. But if we're talking about a pediatric oncology, like I can't imagine there's more than 3 or 4 counties in the state that have that. So how do you think about, or have you faced challenges where it's like, we want to do this thing, we want to give access to it statewide, but like, we don't know if we can for all of our members?
Yeah, and I think those are some of the conversations we have with the state, and some of the state does a really good job of, when there's something to solve for, pulling together like a group or cross-sector group of stakeholders. So providers, insurance, members with lived experience, let's get everyone's perspective and think about this. I think we have to be creative. I think about when I was, again, going back to my intern days, I was on a crisis line before I even graduated grad school. I wasn't a licensed counselor. I had training and I had licensed counselors to back me up, but I was the one answering the phone, supporting the individual that was calling me. So there's things like that. That freed up the resources for licensed counselors to maybe be doing more therapy sessions, while I'm answering the phone, giving people support, they could do more of the specialty care. And I think with the shortage in North Carolina of psychiatrists, of therapists, I think we have to think like that. Like, how do we use a broader workforce? How do we use community health workers? How do we use peers? What are roles and things they can do that maybe historically we always thought, oh, this has to be a licensed clinician? Where do we kind of leverage our talents to have a broader impact, especially in some of the, North Carolina has a ton of rural areas, rural counties. So not only for behavioral health, but for specialty care, we really have to think outside the box.
How much, it's not slack, I don't want to call it slack, but like, if you could snap your fingers and deploy the appropriate provider for the appropriate thing across the entire continuum, like how much do you think we have to grow there? Like, is it a 50 to 100% improvement? Like, do you have any theories about that?
I mean, I do think we need more staff. We need more people wanting to do this work. That's tough too. Not everyone wants to do this. Not everyone wants, especially when you're thinking about working with the population I work with, like a Medicaid population. They're sometimes transient. So where they lived last week may not be the same they're living. Maybe they don't have a phone. So maybe you have to go out to their house and see them. So it just takes a lot of boots on the ground to do that work. Certainly supplementing with virtual care and things like that, but tough to say. I don't know. We need a lot more people, but we also need to use people. We say at the top of their license. So what can a pharmacist do that doesn't have to be the doctor doing it? Or what can a nurse do that doesn't have to be the doctor? Or what can a peer do that can supplement whatever the licensed clinician's doing? Like, everyone has a place in the system. We just have to be creative in how they all work together.
Love that. Let's talk about data. Everyone's favorite subject, data. You've been on the front lines now of deploying lots of new things, which every time there's new things that you're working on, there's inherently a question of, is it working? Is the ROI worth it? Like, should we be continuing to do this? And I've been, I think, humbled throughout my time across providing services that good, effective data that you can trust can be harder to gain than I expected. And I imagine at the scale that you're operating at, that's even more true. There is some truth to the claims that you're seeing. It's about the ground truth that we see in healthcare, but in terms of outcomes data, that can always be challenging. So what have you learned in your time doing this about how to be effective when it comes to evaluating the things that you're trying, how to collect the right data, how to even know what is the right data to evaluate the success of something? Like, what do you have any sort of hard fought lessons that you've learned about data?
Yeah, I mean, I think there's so many. I mean, I think one thing that comes to mind is you can do something right 100 times, but if you do something wrong one time, that may be the complaint you get. That may be the one that gets a lot of attention. So then everyone can have the tendency to act. This is something that always happens. We use that word a lot. Oh, this always goes wrong. People always have challenges accessing care. Well, do they really? Or is it that? So I think that's where data helps us. Like we literally have at our fingertips geomapping. So I can see where do all our members live? Where's their closest pharmacy? Where's their closest provider of XYZ, whatever that is? And where do we have gaps? So where do we have those areas where there are disparities? There isn't a provider for 100 miles. So do we need a telehealth solution there? Do we need a mobile clinic that comes to that area? We also can look at the data and look at, are there disparities in kids, adults, Black, brown, youth, all of those things. I think without data, just kind of before we were guessing, more so. But then on the flip side, I think sometimes you can get so much data that you get, well, let's look at it this way, slicing and dicing it too many ways that you fail to act because we need more data, we need more data, we need more data. At some point, we need to act on the data we have. Then we can look at the back end. Did we see ER rates decrease? Did we see less inpatient care episodes? Did we see people filling their prescriptions at a higher rate? Did we see, I'm a big believer in all those things are great, and those are metrics we have easily accessible in our claims data. But I also think it's really important, how do members feel? How do individuals feel? Like, did this make a difference? Do they feel better? Were they the results they wanted? Because I can think, well, my claims data says they didn't go to the ER, but does that person actually feel better?
Yeah.
I mean, that's and that's harder to collect in the data, but I do think it's something worthwhile to look at.
Have there been any programs that you launched where you were blown away by how effective it was, where you were like, wow, even that exceeded my expectations?
Yeah, I think so we go back to some of our crisis diversion programs and really just seeing how many individuals didn't end up going to hospitalization, that were able to be kept in their homes, kept with their families, in their local communities, just because someone wrapped supports around them. Those are the things that I really take home. The dollars, the numbers, all of that's important. But when you can see those families really stay together, and know that was because somebody went to their house and supported them in a different way. Those are the things that really make this job worth it.
I was struck the first time that I actually got the opportunity to go to a hospital. It was in Western North Carolina, and to see what ED boarding actually was, because I hadn't done that here. Yeah. And the trauma that you can have just from being stuck in a place like that compounds massively whatever was going on that got you there.
Yeah. And
you mentioned earlier that, again, very in your earlier work, that there was so much trauma that people were not identifying, and identifying in youth that this was troubled behavior or bad kids, when in reality they had just been through really hard things. It's like that's an unquantifiable impact, right, that a better service, a more appropriate service has on that member. And I sort of wonder, do you think about, we talk about trauma-informed care, right? Yeah. Which is the provider in front of you understands enough about trauma to know and ask the right questions to assess whether or not this is a prevalent factor. Do you think about a trauma-informed system? And if so, what would that look like?
I think that's where we need to be, especially, we've all been through so much. Kids go through so much now. There's a school shooting I mean, routinely. Like, that's traumatic, whether you see it on the news, whether they did a drill at their school, like all of that. So we really need to have that lens from everyone in our system, families, schools, clinicians, because that's, really the best way to approach individuals. And I go back to some of my work I've done with individuals with intellectual and developmental disabilities who maybe they're nonverbal. Maybe they can't communicate in the same way. They can't tell you what's going on for them. But people who know them well can say, hey, loud noises or whatever that is that triggers them and that triggers their trauma. So if the police have to come or the ambulance has to come, can we do that without sirens and lights? Because that's just going to make the situation worse. And that's just on a case by case. That's really just people thinking about, okay, they're a person first. What does that person need to be supportive? And that's a key piece of trauma-informed care. Whether people realize it or not, they may not. The family member who's advocating for that individual may not call it trauma-informed care, but that's what they're doing. They're helping the situation to avoid re-traumatizing individuals.
Yeah, I mean, it's so obvious when you have a conversation sitting in a podcast studio talking about it, but like, I also can understand that if you're an ER, an emergency responder, right, and you're going and seeing 20, 30 people a day, like at a certain point, I can imagine that you get burnt out or you get overstressed and you forget that like on the other side of who you're helping is a person with a story who was going through something very serious. And so it reminds me how hard it is to actually do well, and to ask everyone and to essentially be these like enlightened angels and go to, support others in this moment of difficulty is really hard. But despite that, to see the success of like a MORC program and how much it's able to help, I think makes me really optimistic that there are other hard areas that we can do this to as well. Do you have a sense of what you feel like is the next big domino? Like, is there something that you've seen that's either been piloted or running that you all have, or that the state is doing that you're really excited about, that like it seems like it's going to be another next big thing?
I don't know if it's the next big thing, but we've seen a lot of success with it. So, you talk about police, paramedics, first responders, people all do that because they're helpers, right?
Yeah.
You get into that because you want to help people. And we've seen the significant impact of crisis intervention training has to them. So police departments, depends on the county, depends on the sheriff's office, but some of them have really implemented, all of our officers go through that training. And we've seen what a difference that can make I talked to our police officer just last week about a situation, and their approach was, well, we're going to get this team that's a community-based team to go out there because they understood this individual we were talking about had some mental health concerns. And they approached it from a kindness of, we don't want to lock them up. We don't want, how can we approach the situation in the best way to avoid re-traumatizing, but do what's needed. But really, so I think we're getting there, but I think those are the types of training support. People need to approach things with that lens.
Love that. Back to more training, more education. I love it. A theme here, you might say. Let's talk about your time as a professional. You are working in a large organization, serving a lot of people. There's a lot of different stakeholders. It's not always just the clinical folks who are in the room. There's sometimes the financial, the business, all the others. What have you found that has been the most difficult part about being the clinical voice in the room, and the one who sees and has been there? Like, what have you found difficult about communicating the realities on the ground to some of the other folks you work with? And then maybe I'd love to know on the flip side, like, what have you been surprised by your colleagues becoming receptive to and becoming excited about that you thought might be more challenging to get them on board with?
Whether it was when I was a clinician working for an agency or now at a large insurer, finances are reality. We need finances to run a business. You need, you got to keep the lights on when you're working in an office, all of that stuff. So that is a reality, and that's a part of it. But I think on the flip side, what I found is if you do the right thing by the members, and you can look, look at my data and I'm like, wow, this service is really trending up. Is this appropriate? Where are the trends, the patterns? And you can dig into that and make sure people are delivering good care, you're getting the outcomes you want, you're investing in the right supports and services. And then that overutilization that maybe is not appropriate, that you find the right ways to address that. But you're putting the members at the forefront to make sure they get the best care they can. I've found that in and of itself rights the system, saves the money, saves the dollars, but you just have to focus on the quality piece of it.
As you're talking, I don't know why I had this analogy pop in my head, but it's kind of like you're the explorer, where like everyone you work with, they have all the information, but you're kind of the only one who really knows what's going on down there, or at least you know probably more than they do. And you're kind of just connecting the dots for them of like, hey guys, this problem that we're all identifying, the reason is because of X, Y, or Z. And we might have a solution here. So do we all want to get on board and jump? Right? It's kind of like you're connecting the dots for them. Is that how you see your role?
A little bit, yeah. I mean, definitely, I bring that clinical perspective, but I have to have that operations lens. So, both sides of that. And I think the state has really done a great job of that too. I mean, they've looked at how do we get more effective mobile crisis? How do we get behavioral health urgent cares? So in the long run, that's helping with the ED boarding that people are talking about, or the expenses of inpatient care for people who really didn't need to be there because we're treating them in their local communities and can have that continuity of care. Maybe it's better for them. They're walking into an environment where somebody is trained for what they need versus if I walk into an ED, whether I have a broken arm or a mental health condition, there may or may not be a specialist in that ER for whatever it is. If I need an orthopedic surgeon, maybe they're not there. They have to be on call. So whereas if you go into a behavioral health urgent care, you're walking into an environment that people are trained and supported. They know kind of how to intervene most appropriately.
Got it. What was one career decision that you made that really changed the trajectory of, I don't want to impart on any trajectory. What was one thing that you look back and you're like, wow, that really changed my trajectory?
I think it was like when I transformed from being a clinician to kind of a administrator operations. One of my supervisors, I was a couple years into practicing, and I trained to be a family therapist. I was going to be a family therapist. I was going to do therapy. That's what I was
committed.
Passionate about. And one of my early roles, I think we're having an audit or something. She's like, yeah, you have this operations mind. You're like really logical. You're going to go do some of this stuff. And I would have sworn, no, absolutely not. So fast forward, years, and I was a clinical supervisor for a while. So not doing direct care, but supervising those who were, looking for new opportunities. We all want growth at some point, changing careers. And I'm like, well, the health plan has a lot of opportunities. Let me just try that. Not really knowing what that trajectory would look like. And it has evolved my whole career to going from being kind of on the side of things, so reviewing individual requests, to developing programs. And I love it. So whatever that supervisor saw way back then, really, she saw something that kind of led me down this path. So
love that. I feel like some people just have vision. They just see people. They're like, I know exactly where you're going to go. You got to trust them. All right. Thank you for being here. My last question I ask everyone is, if you could snap your fingers and change one thing today about youth mental health that you think would radically improve the lives of all of our young people, what would you snap your fingers and do?
I personally would love to see universal screening. So it to be as common as you go to your wellness visit every year or whatever that is. Let's make sure everyone is screened for mental health and knows what to do when they screen. Because I do think we're seeing increase in screening, but then the problem is, okay, someone screens positive for anxiety or depression. Okay, now I don't know what to do with that information or where to refer them. So to see a system that really works, that we identify people with needs earlier, that we get them connected to the care they need earlier, and we support them not only in their treatment journeys, but what are those things that just kids need to be kids? I think sometimes in our treatment worlds, we forget that. We get so focused on treatment that we forget these are still kids who may want to join the soccer team or something that's positive for them instead of just focusing on treatment.
Love it. Thank you, Christine. Really appreciate it.